Okay, let's unpack this. Today we're taking a deep dive into something that, well, it affects millions of people around the world, but often goes unnoticed or is deeply misunderstood.
Yeah.
We're talking about lymphedema, and we're pulling our insights from a key medical chapter and, its related research.
That's right. Our goal today is to really explore this condition, to understand what it is, how it affects the body, how clinicians figure out what's going on,
Right.
and probably most importantly, what it means for the people actually living with it day in, day out.
It might sound a bit technical, diving into lymph vessels and fluid dynamics,
Uh-huh.
but we're going to try and guide you through this like a journey. We want to find those surprising facts, the real aha moments, and give you just enough information so you feel really informed without getting totally lost in the medical jargon.
Absolutely. Because it is so much more than just, simple swelling. It's complex, it's chronic, impacting over 150 million people globally, with a history in medicine that's been, well, surprisingly overlooked at times, actually.
So to start understanding this, let's maybe meet someone whose story kind of helps illustrate the challenge. Let's call him SR.
Okay.
He's 54, and he recently developed this painless swelling just in his left leg. It gets worse later in the day.
Yeah.
It doesn't really seem to go down much when he puts his leg up, and he feels this heaviness and aching sensation, especially with his job. He's busher, stands a lot.
Right, lots of standing.
And he doesn't recall any specific injury or infection recently.
SR's story is, unfortunately, pretty typical. And it immediately makes you ask questions, right? What's causing this swelling? Is it just fluid, and why isn't it resolving with elevation?
Exactly.
So to get to the bottom of it, we really need to understand what lymphedema fundamentally is.
All right, so lay it out for us. What is it at its core?
Fundamentally, lymphedema is swelling, but it's swelling that happens because a very specific type of fluid, lymph fluid, builds up in the body's tissues, usually just under the skin.
Okay.
And crucially, this isn't just watery fluid, it's rich in protein.
Protein-rich fluid buildup.
Oh, okay.
And is it always just like arms or legs?
That's where we see it most often, definitely. But it can absolutely affect other parts of the body too. Face, head, neck, the chest, abdomen, pelvis, even the genital area. It really depends on where the lymphatic system is struggling.
And what causes this specific fluid, this protein-heavy lymph, to collect like that? What's going wrong?
It happens when there's a breakdown in the lymphatic system's ability to do its job. Either the tiny vessels that are supposed to collect fluid from the tissues aren't working right, or the larger vessels that transport that fluid back towards the heart are blocked or damaged in some way. They just can't move that fluid back into the bloodstream like they should.
One thing the sources really highlighted, especially for later stages, is something called non-pitting edema. Now, I think most of us know pitting edema. You press the swollen spot, your finger leaves the dent.
Right, exactly.
But what's non-pitting? And how is this swelling different from, say, swelling you might get from heart failure or vein problems?
That's a really, really important distinction. In the early stages of lymphedema, you might see some pitting because it's mainly fluid buildup at that point.
Okay.
But as the condition progresses, that protein we mentioned, the protein that's stuck in the tissues, starts to cause problems. It acts like an irritant, basically. It stimulates chronic inflammation and encourages the growth of tough, fibrous tissue, scar tissue, essentially.
Ah, so it's firmer.
Exactly. The tissue becomes firm, dense. So when you press on it, it doesn't really leave that indentation anymore. That's non-pitting edema. Swelling from, say, heart failure or venous insufficiency is usually more pitting because the fluid itself is different and the underlying pressure issues are different. It's not primarily about protein buildup in those cases.
The numbers you mentioned are huge, over 150 million worldwide, maybe over 1% here in the U.S.
Yeah.
But the sources also said it's really hard to get accurate figures. Why is that?
Yeah, it's surprisingly tricky. There are several reasons. For one, there isn't one single universally agreed upon definition that all researchers use consistently. The surveys haven't always been done the same way over time. And maybe the biggest factor is that whether someone develops lymphedema or how severe it gets depends so much on their individual factors, their genetics, their overall health, and exactly what kind of damage happened to their lymphatic system and how bad it was. It's very variable.
Got it. Hard to count because it looks different in different people and depends on their whole story. Now, the causes, they're generally split into primary and secondary. What's the main difference there?
So primary lymphedema means the problem is with the lymphatic system itself, how it developed. Maybe it was a congenital thing present from birth, Or maybe it just developed later for unclear reasons, but the issue is inherent to the system.
Okay.
Secondary lymphedema means the lymphatic system was presumably normal to start, but then something else happened to damage it. An injury, an infection, surgery, radiation. There's a known external cause.
And speaking of causes, are the main ones the same everywhere?
Not at all. And this is a really striking contrast. Globally, the #1 cause by far is a parasitic infection called filariasis.
Filariasis.
Yeah, spread by mosquitoes and flies. It affects well over 100 million people, mainly in tropical and subtropical regions. But here, in industrialized countries like North America and Europe, the leading causes are actually cancer and cancer treatments.
Wow.
Particularly surgery and radiation therapy that involve removing or treating lymph nodes. That's a huge difference based purely on geography and, well, healthcare context.
That really is a massive difference. And you mentioned it's often progressive. It gets worse over time.
Yes, that's a crucial characteristic. If it's not managed, lymphedema typically increases in size and severity. It's not just a cosmetic thing, although the cosmetic changes can be significant. It can become really disabling, affecting how people move and live their lives.
It's interesting the sources mentioned that the lymphatics themselves were actually recognized way back by physicians like Hippocrates and Aristotle.
Yeah, ancient times.
But the actual condition of lymphedema seems to have been somewhat neglected until more recently in medicine.
It really highlights how complex this system is, doesn't it? And how long it took for us to truly grasp its function, and importantly, what happens when it malfunctions. The structures were seen, but connecting them to this chronic, progressive swelling, that understanding came much later.
And the tough reality, which the sources make very clear, is that right now, there's no cure.
That's correct. There's no magic bullet. The entire focus of current treatment is on management. Reducing the swelling, trying to stop it from getting worse, and preventing serious complications, especially infections.
Okay, so to really get what goes wrong, we probably need a better picture of how the healthy lymphatic system should work. The sources use an analogy. I liked thinking of it as the body's hidden highway.
It's a great analogy, I think. It really is like a parallel circulatory system running alongside our blood vessels. But its main job isn't carrying oxygen. It's handling the fluid, the large proteins, and the waste products that the blood circulation either can't handle or leaves behind in the tissues.
So what's the actual fluid moving on this highway? What is lymph?
So lymph fluid starts out as interstitial fluid. That's the fluid bathing all our cells. Normally it's clear, colorless, although in the digestive system, after a meal, it picks up absorbed fats and turns milky. That's called chyle.
Chyle, okay.
And we make a lot of this stuff. Maybe 4 or 5 pounds worth of lymph flows through the system every day. It's mostly water, but critically, it contains about half of all the protein that leaks out of our bloodstream daily. The lymphatics are vital for getting that protein back. It also carries white blood cells for fighting infection, and unfortunately, it can also transport unwanted things like bacteria, viruses, cell debris, even cancer cells.
And those lymph nodes we always hear about, what's their role on this highway?
Yeah.
Checkpoints.
Exactly. They're the filters, the purification centers. We have hundreds of them. 600 to 700, maybe these small bean-shaped organs dotted throughout the body, often in clusters like in your neck, armpits, groin. Their job is to filter out those unwanted passengers, bacteria, debris, abnormal cells, before the lymph fluid gets returned to the blood. They also help regulate the protein concentration in the lymph, which is important for fluid balance. And that whole concept of a sentinel lymph node in cancer staging, that comes directly from this filtering function, finding the first node that drains a specific area.
Okay, fluid, filters. What about the roads themselves, the vessels?
Right. The lymphatic vasculature, it's this whole network of tubes. It starts incredibly small with these tiny blind-ended vessels called initial lymphatics or lymphatic capillaries. They're everywhere in our tissues, except for a few places like the central nervous system or the cornea of the eye.
Blind-ended, so they just sort of start.
Yeah, they just begin right there in the tissue.
Yeah.
They're structured a bit like blood capillaries, but have these unique overlapping cells that act like little one-way flaps or valves. When pressure builds up in the tissue fluid outside, these flaps get pushed open, allowing fluid and those large protein molecules to enter the lymphatic vessel. But they can't easily flow back out. It's a clever design.
Like tiny one-way doors.
Exactly like that. Then, these tiny capillaries merge into slightly larger vessels called precollectors. They're a bit less permeable, but they have more developed valves inside to keep the fluid moving in one direction.
Okay.
And these precollectors then lead into the main transport vessels, the lymphatic ducts or collectors. These are the ones that carry lymph towards the center of the body. often running alongside the major arteries and veins. They have thinner walls than veins, but they have smooth muscle in those walls and lots of internal valves, much closer together than in veins.
And in the arms and legs, are there specific main routes?
Yes, broadly speaking, there are two main systems. There's a superficial system running just under the skin in the fatty tissue, which handles about 80% of the lymph drainage from the skin and subcutaneous layers.
Okay, most of it.
And then there's a deep system located beneath the fascia that drains the muscles, bones, joints, and deeper blood vessels. These two systems eventually connect and drain into the major lymph node groups, like the ones in the groin, inguinal nodes, or armpit, axillary nodes.
And where does all this collected filtered fluid finally go? Where does the highway end?
It all funnels into two main, large collecting channels up in the chest area. The biggest one is the thoracic duct.
Thoracic duct. Okay.
It collects lymph from the entire lower body, the left arm, and the left side of the head, neck, and chest. It also receives that fatty chyle from the intestines via a collecting sac called the cisterna chyli, usually down near the second lumbar vertebra. The thoracic duct is a major conduit, moving maybe 1.5 liters of lymph a day.
Wow.
Then there's the right lymphatic duct, which is smaller. It drains the upper right part of the body, right arm, right side of the head, neck, and chest. It handles about the remaining 25% of the lymph load.
And both of these empty where?
Both of these large ducts empty directly back into the bloodstream, right near where the subclavian veins from the arms meet the jugular veins from the head and the base of the neck. So that filtered fluid and recovered protein rejoins the general circulation there.
It really is this whole parallel system constantly working behind the scenes.
Yeah.
So how does the fluid actually get pushed along this network, especially going uphill from the legs, say?
Yeah.
What drives the circulation?
Well, it starts with the fundamental physics of fluid exchange between the blood capillaries and the tissues, Starling's forces, the balance between hydrostatic pressure pushing fluid out and oncotic pressure pulling it back in.
The push and pull, right?
Exactly. So about 24 liters of fluid filter out of our blood capillaries every single day. Now, most of that, maybe 85 to 90%, gets reabsorbed directly back into the venous end of the capillaries and the small veins.
Okay.
But that leaves about 10 to 15%, roughly 2 to 4 liters a day, that doesn't get picked up by the veins. That's the fluid, along with those leaked proteins that the lymphatic system has to collect and return.
So the lymphatics are basically handling the overflow, the remainder. How do they move it then? Against gravity sometimes.
It's a combination of factors. First, you have that initial absorption into the capillaries driven by tissue pressure differences. Then, those one-way valves throughout the entire system are absolutely critical. They prevent backflow, ensuring the lymph only moves forward towards the heart.
Valves are key.
Very key. But maybe the most active component, especially in the larger collecting vessels, comes from segments of the vessel wall that contain smooth muscle. These segments are called lymphangens.
Lymphangens, like little hearts in the vessels.
You can almost think of them that way. They're like tiny intrinsic pumps built right into the lymphatic vessels. They contract rhythmically on their own.
Wow.
Even at rest, they're contracting maybe 6 to 10 times a minute. But what's really interesting is how much their activity increases. Things like external compression from surrounding muscles contracting when you move.
Like walking.
Exactly, like walking. Also, the pulsation of nearby arteries, changes in pressure in your chest when you breathe, even just the stretching of the lymphangian wall as it fills with fluid. All these things stimulate these segments to contract more forcefully and frequently. During exercise, they might contract 60, even over 100 times a minute.
So movement is literally helping pump the lymph along. That makes sense. What about flow through the nodes? Does that slow things down?
It does. Fluid enters a node through several afferent vessels, percolates through the filtering sinuses inside, and then exits through fewer efferent vessels, so it naturally slows down there for the filtering process. And this is where problems can arise if nodes are removed surgically or damaged by radiation. That area becomes a bottleneck. Scar tissue makes it very difficult for lymph to get through.
Right. And what about that big thoracic ducts? How does flow keep moving out that?
It's helped by the same mechanisms, the intrinsic pumping of lymphangens within its walls, external compression, but it also gets a significant boost from breathing. When you take a deep breath in, the diaphragm moves down and the pressure inside your chest cavity drops. This creates a kind of suction effect that helps pull lymph up the thoracic duct and encourages it to flow into the low-pressure veins in the neck.
Okay, so that's the system working beautifully. Now, let's get back to what goes wrong in lymphedema. What's the core problem? The pathophysiology.
The fundamental issue is a failure in that transport system. Either the vessels or nodes weren't formed right from the start, that's primary lymphedema, or they've been damaged, blocked, or removed, secondary lymphedema.
And that directly leads to the fluid backing out.
Precisely. Because the lymphatic system can't drain the fluid and protein away effectively, they accumulate in the interstitial space, the tissue between the cells, and that protein buildup is really central to the problem. It increases the osmotic pressure out in the tissues.
Pulling more water in.
Exactly. It holds on to water, making the swelling worse.
And you mentioned earlier the sources emphasize that in lymphedema, the blood capillaries are usually working normally.
Yes, that's a key distinction the sources make. Generally, the rate at which fluid filters out of the blood vessels isn't the primary problem. The problem is the failure of the lymphatic system to drain away the normal amount of fluid and protein that does filter out. The drainage system is broken or overwhelmed.
And why is that protein buildup so detrimental? It sounds like it creates a downward spiral.
It absolutely does. This is why lymphedema tends to be progressive. That stagnant, concentrated protein essentially acts like a foreign substance, an irritant in the tissues. It triggers a chronic, low-grade inflammatory response.
Okay, inflammation.
And this chronic inflammation then stimulates fibroblasts, the cells that make connective tissue to lay down collagen. You get fibrosis or scarring.
Ah, the non-pitting part.
Exactly. This fibrous tissue makes the limb feel firm and hard. But worse than that, the scarring itself further damages the remaining functional lymphatic vessels in the area. It constricts them, makes their walls thicker, impairs their ability to contract and absorb fluid. It's a vicious cycle.
So initial damage, fluid protein backup, inflammation, scarring, more lymphatic damage, worse backup.
You got it. The lymph stasis and protein overload also impair the local immune response, making the area more prone to infection, which causes more inflammation and scarring. Even the process of new blood vessel formation, called neoangiogenesis, that happens with inflammation, can inadvertently damage nearby lymphatics. The end result is that characteristic non-pitting edema and thickened, dense skin of later stages.
And you mentioned a surprising fact that visible swelling might not appear until there's quite a lot of fluid.
Yeah, one source mentioned it might take up to a 30% increase in fluid volume in the affected area before swelling is even noticeable visually. So someone could have underlying lymphatic damage, maybe stage 0, feel some heaviness, but not have obvious swelling until the system gets stressed, like with heat, exercise, or air travel. But once that symptomatic swelling appears, it means the drainage capacity is permanently overloaded. And in later stages, just putting your feet up won't make it go away.
That progression leads us nicely to the staging system. The sources mention the International Society of Lymphology, or ISL, classification. How does that work?
Right. The ISL system is widely used. It stages lymphedema based mainly on two things: the physical characteristics of the tissue, particularly how much fibrosis or scarring is present, and whether or not the swelling reduces when the limb is elevated.
Okay, can you walk us through those stages?
Sure. Stage 0 is sometimes called the latent or subclinical stage. Here, the lymphatic system has been damaged or compromised, but the swelling isn't actually visible yet.
But something's wrong.
Exactly. The transport capacity is reduced. The person might feel symptoms like heaviness, fullness, or aching in the limb. This stage can last for months, even years, before obvious swelling appears.
Okay, stage 0, then stage 1.
Stage I is the reversible stage. Now you have visible swelling due to the accumulation of protein-rich fluid. At this point, the edema is typically pitting. You press it, it leaves a dent.
Ah, pitting.
Yes. And critically, in stage 1, the swelling usually resolves, or at least significantly improves, with limb elevation. The skin texture is still relatively normal, soft, and elastic.
So this is really the stage where intervention can make a big difference in getting the visible swelling down.
Absolutely. Early management here is key to prevent progression, because stage 2 is considered irreversible.
Irreversible, okay. What defines stage 2?
In stage 2, that chronic inflammation and protein buildup have led to significant fibrosis, scarring, and hardening of the tissues. Now, the edema is usually non-pitting or pits only with very strong pressure.
Right, the firmness.
And the swelling does not substantially reduce just with elevation anymore. The skin starts to feel denser, thicker. Significant structural changes have happened in the subcutaneous tissue, even if they aren't always dramatically obvious from the outside until the limb is really challenged.
In the final stage.
Stage 3 is sometimes called lymphostatic elephantiasis. This represents the most advanced stage, resulting from long-term severe destruction and blockage of lymphatic pathways. It's often worsened by recurrent episodes of infection.
What does it look like?
The limb becomes massively enlarged, sometimes more than double its normal size. The skin undergoes dramatic changes. It becomes extremely thick, hard, almost woody or bark-like in texture. You can see deep skin folds, discoloration, and sometimes warty growths called papillomas, which can leak lymph fluid. There's significant loss of function and mobility.
That progression sounds incredibly challenging.
Mm.
Beyond the swelling and skin changes, the sources mention some other serious potential complications.
Yes, unfortunately there are. One very rare but extremely serious complication of long-standing chronic lymphedema is a type of malignant tumor called lymphangiosarcoma.
A cancer.
Yes, it's a sarcoma that arises from the damaged lymphatic vessel lining itself. It's rare, less than 1% of cases, but it's aggressive. Historically, it was often associated with lymphedema that developed after mastectomy and radiation for breast cancer. That's called Stewart-Treves syndrome.
Okay.
But it can occur in other types of long-term primary or secondary lymphedema too. It's thought that the chronic lymphedema environment itself somehow triggers the malignancy.
What are the warning signs?
It often appears as a new, flat, or slightly raised purplish or bluish lesion on the affected limb, sometimes looking like a bruise that doesn't go away or wasn't caused by injury. It can develop satellite lesions or ulcerate. Unfortunately, it tends to metastasize early and has a poor prognosis. Other cancers, like certain lymphomas or skin cancers, have also been reported to occur more frequently in limbs with chronic lymphedema.
That's frightening. What about other complications? You mentioned Kyle earlier.
Right, another potential issue, particularly if the blockage is higher up in the system, like in the abdomen or chest, is something called chylous reflux.
Reflux of that milky fluid from the gut.
Exactly. If the main lymphatic channels draining the intestines, like the cisterna chyli or the thoracic duct, are blocked or incompetent, that fatty lymph fluid, the chyle, can back up. It can leak into the chest cavity, chylothorax, the abdominal cavity, chylocystites, or even the urinary system, chyluria.
Wow.
In severe cases, this lipid-rich chyle can reflux all the way down into the lymphatic vessels of the pelvis, scrotum, or lower extremities. This can cause swelling and sometimes tiny blisters or vesicles on the skin that leak this milky fluid. It points to a major disruption of central lymphatic pathways.
The sources also briefly touched on different ways to classify severity beyond just the stages.
Yeah, there are other systems used, often for tracking treatment progress or research. For instance, the American Physical Therapy Association, APTA, has guidelines based on circumferential measurements comparing the affected limb to the other side. Mild might be less than a 3-centimeter difference, moderate 3 to 5 centimeters, severe over 5 centimeter difference at certain points.
Okay, based on size difference.
Right. And then there's a system used in cancer research, the CTCAE, Common Terminology Criteria for Adverse Events, which grades lymphedema based on clinical signs like skin changes, and importantly, how much it limits a person's ability to perform daily activities, from trace swelling to severe limitations requiring help with self-care.
Okay, let's go deeper now into why this happens, the etiology. We talked about primary and secondary, but what are the specific causes? And maybe just as importantly, what are the triggers that can bring on symptoms or make them worse in someone who's already at risk?
Right, so for primary lymphedema, it's really about the lymphatic system itself not developing properly. It can be congenital, meaning present right at birth. This is actually quite rare, maybe 10–15% of all primary cases. Milroy disease is an example, often familial, linked to a specific gene defect affecting lymphatic vessel growth.
Okay, congenital is rare. What's more common?
The most common type of primary lymphedema by far is lymphedema precox. Precox meaning early. This typically shows up around puberty or in early adulthood, usually before age 35. It accounts for maybe 70–80% of primary cases. Meech disease is a hereditary form, often falling in this category, more common in females, sometimes linked to another gene mutation affecting valve development. Often the onset seems to correlate with things that increase lymphatic load, like growth spurts or hormonal changes, overwhelming a system that was already underdeveloped.
And tarda.
Lymphedema tarda is simply primary lymphedema that starts later in life after age 35. The underlying cause is still presumed to be a developmental issue, but it just doesn't manifest until later.
Okay, so primary is often rooted in genetics or development. What about secondary lymphedema, the acquired type?
This is where we see those external causes we touched on. Globally, filariasis is the big one, those parasitic worms physically blocking and inflaming the lymph vessels.
Right.
But here in North America and Europe, the #1 cause is cancer treatment, specifically surgery that removes lymph nodes, like axillary nodes for breast cancer or inguinal nodes for melanoma or gynecological cancers. and a radiation therapy to those areas.
Does the extent of surgery matter?
Generally, yes. The more nodes removed or the wider the area irradiated, the higher the risk. But it's important to know that lymphedema can still occur even with less invasive procedures like sentinel node biopsy, though the risk is lower. Chemotherapy can also contribute sometimes through its effects on tissue healing and inflammation.
What about things like injuries?
Absolutely. Trauma can directly damage lymphatic vessels or nodes. Think pelvic fractures, severe burns, crush injuries, even some surgical procedures like liposuction if not done carefully. Trauma also increases the risk of infection.
Which makes things worse.
Exactly. Infection is both a potential cause and a major complicating factor. Any infection causes inflammation and increases fluid load, challenging the lymphatics. But recurrent infections, especially bacterial skin infections like cellulitis or erysipelas, or infection within the lymphatic vessels themselves, lymphangitis, cause direct destruction and scarring of those vessels, permanently reducing drainage capacity. And people with already damaged lymphatics are more susceptible to infection because their local immune surveillance is impaired.
Are there other causes?
Tumors? Yes. Tumors themselves, whether they're cancerous or benign, can cause secondary lymphedema simply by growing large enough to physically block or compress lymphatic vessels or nodes. Cancer can also spread through the lymphatic system, clogging it up. And then there's what's called iatrogenic damage harm caused by medical treatment. Radiation therapy is a big one, causing fibrosis that restricts vessel function. Direct surgical injury during other procedures, even things like repeated punctures in the groin for vascular access, can damage lymphatics. Chronic venous insufficiency, severe vein problems can also lead to or worsen lymphedema because the venous system fails to adequately return fluid, overwhelming the lymphatics over time, sometimes called phlebolymphedema.
So that covers the underlying causes, but the sources made a really important distinction about precipitating factors or triggers, things that don't cause the underlying lymphatic problem, but can make symptoms appear or suddenly worsen in someone who already has a compromised system.
Yes, this is critical for patient education and prevention. These are stressors that a healthy lymphatic system could easily handle, but an impaired system just can't cope with the extra load. The core issue is usually anything that significantly increases blood flow and fluid filtration into the tissues, or anything that further impedes lymph outflow.
Like what specifically?
Heat is a major one. Anything that causes vasodilation, increased blood flow to the skin. So hot weather, hot baths or showers, saunas, hot tubs, even using heating pads on the affected area, or handling hot items like oven dishes without protection on an at-risk arm.
Makes sense. More blood flow, more fluid to drain.
Exactly. Overuse or strenuous activity with the affected limb, especially against resistance like heavy lifting, scrubbing, vigorous repetitive motions, can also increase metabolic activity and fluid production temporarily, potentially overwhelming the system. Aggressive massage, different from gentle MLD, can sometimes be a trigger. Even changes in atmospheric pressure, like flying in an airplane cabin.
Oh, flying.
Yes, the lower cabin pressure can allow more fluid to shift into the tissues.
Yeah.
Scuba diving, particularly the pressure changes during ascent, can also be a factor.
What about clothing or pressure?
External constriction is a big one. Tight clothing, tight jewelry like rings or watches on an affected limb, even a blood pressure cuff inflated tightly on that arm can impede the already sluggish flow. Sleeping position, if it consistently compresses the limb, can contribute.
And you mentioned infection earlier as a cause, but it's also a trigger.
Absolutely.
Yeah.
Any break in the skin is a potential entry point for bacteria. An infection causes massive inflammation and increased blood flow. So things like cuts, scrapes, insect bites, pet scratches, blisters, even minor hangnails or injections in the affected limb can trigger an episode of cellulitis, which then dramatically worsens the lymphedema and can cause further long-term damage.
Wow, so skin integrity is huge.
Paramount. Other triggers can include significant weight gain. Obesity is a major risk factor for developing or worsening lymphedema, especially after cancer treatment. Pregnancy due to hormonal changes and increased fluid volume. Certain chronic illnesses that affect fluid balance, like heart failure or kidney disease. Even some medications, like certain calcium channel blockers used for blood pressure, can sometimes increase lower extremity swelling, though they don't cause the underlying lymphedema itself.
That's a really extensive list of potential pitfalls. It really highlights how careful someone with a compromised lymphatic system needs to be. So how do clinicians take all this information, the history, the potential causes, the triggers, and actually diagnose lymphedema?
The assessment process is absolutely key, and it usually starts with a very thorough history and a careful physical examination. Clinicians are looking for those risk factors we discussed. Is there a family history suggesting primary lymphedema? Is there a known secondary cause like cancer treatment, surgery, trauma, or history of recurrent infections in that limb? Age is important too. New onset swelling in someone older, say over 60, raises red flags for other serious causes that need urgent investigation. And obesity is always considered a significant contributing factor.
What kind of things do they ask about specifically in the patient's history?
They listen really carefully to how the patient describes the swelling. When did it start? Was it gradual or sudden? Is it painful? Lymphedema itself is often painless, maybe just heavy or aching. Significant pain might suggest infection or another issue like nerve compression. Does it get better with elevation? Worse at the end of the day. Are there feelings of heaviness, tightness, fullness? Any skin changes, notice dryness, thickening, leaking fluid? Any history of redness, warmth, fever, chills, suggesting infection in that limb? They'll ask specifically about potential causes, cancer history, surgeries, injuries, travel to filariasis, endemic areas, and very importantly about comorbidities, other health problems like heart, liver, kidney disease, diabetes, venous issues, and how is the swelling impacting their life, their job, activities, clothing, mood.
And after the history, you mentioned the different diagnosis is crucial.
Absolutely critical. Before labeling it lymphedema, the clinician must consider and rule out other possible causes of limb swelling. Some of these are medical emergencies like deep vein thrombosis, DVT, a blood clot. Others include congestive heart failure, liver disease, kidney disease, severe chronic venous insufficiency, lipedema, which is a disorder of fat distribution, not fluid, though they can coexist, a tumor pressing on veins or lymphatics, even side effects from certain medications. So, especially with new onset swelling or swelling that seems unusual, ruling these other things out is paramount.
So history gives clues. Ruling out other conditions is vital. What happens during the physical exam? What are they looking for?
The physical exam is often where the suspicion for lymphedema becomes very strong, or even confirmed clinically. They look carefully at the appearance of the limb. Is the swelling symmetrical or asymmetrical? Is it just the foot hand or the whole limb? They compare it to the other unaffected limb, often taking circumferential measurements with a tape measure at specific points every few centimeters up the limb to quantify the difference.
What about the shape?
Yeah, the characteristic shape can be a clue. Often it's a rather uniform pole-like swelling that kind of obliterates the normal contours. Sometimes the ankle or wrist creases might look deeper because the swelling is above and below them. Swelling on the top of the foot, sometimes called a buffalo hump, is common, and the toes or fingers might look tense, sausage-shaped, or squared off. Figure 23-2 in the source material shows some of these typical appearances.
And the feel of the swelling, pitting versus non-pitting.
Exactly. They'll press on the swelling to see if it picks, which helps determine the stage as we discussed. They'll feel the skin temperature warmth could indicate infection. They assess the skin texture. Is it soft, or is it starting to feel firm, thick, leathery? Are there any signs of hyperkeratosis, thickening of the outer skin layer, skin folds, warty changes, verrucae, or little blisters, vesicles that might be leaking clear lymphuria or milky chyluria in very advanced cases? They look for cracks, fissures, signs of fungal infection, like between the toes, as these are entry points for bacteria.
And the stemmer sign, you mentioned that earlier.
Yes, the stemmer sign is a classic clinical test. The examiner tries to gently pinch and lift a fold of skin at the base of the second toe, or sometimes the second finger.
Okay.
If they cannot lift the skin fold because the tissue there is thickened and bound down due to subcutaneous fibrosis, that's considered a positive stemmer sign. It's a strong indicator of lymphedema, particularly in the lower limb. A negative sign doesn't rule it out completely, especially in early stages, but a positive sign is highly suggestive.
They also check pulses and things like that.
Yes, they'll try to palpate pulses, although this can be difficult if the swelling is severe, so using a handheld Doppler ultrasound might be necessary. Assessing arterial circulation is important, especially if considering compression therapy. They'll also palpate for any enlarged lymph nodes elsewhere, check the abdomen for any masses, and do a general musculoskeletal and neurological checkup of the limb.
The sources also pointed out that the patient's age really influences the assessment and management approach.
Absolutely. For infants or children with congenital lymphedema, the focus is often on managing the condition with compression from a very early age, supporting the parents, and addressing the psychosocial impact of growing up with a visible difference. For adolescents or young adults presenting with lymphedema precox, it's important to identify potential triggers like growth spurts or injuries, and again, address body image and self-esteem issues which can be significant at that age.
And for women?
For women of childbearing age, managing lymphedema during pregnancy requires extra diligence with compression and elevation due to the increased fluid volume and pressure from the growing uterus. Clinicians are also usually cautious about prescribing estrogen-containing oral contraceptives because of a potential increased risk of blood clots in women who may already have compromised circulation.
What about older adults, say over 60 with new swelling?
That requires immediate and thorough evaluation to rule out those other serious underlying causes we mentioned: heart failure, kidney or liver problems, malignancy causing obstruction. Managing lymphedema in the elderly is also frequently complicated by other coexisting health conditions.
Like what?
Like congestive heart failure, which might limit the type or amount of compression that can be used safely. Osteoarthritis can make it physically difficult for them to apply bandages or garments themselves. Obesity is common and increases infection risk and limits mobility. Diabetes is a huge consideration requiring meticulous foot care, careful monitoring for infection, and caution with compression due to potential neuropathy or poor circulation. Infections might also present atypically in older adults, sometimes just with confusion or weakness rather than obvious local signs. And long-standing lymphedema in this age group can present with very challenging skin changes, woody texture, deep crevices, weeping areas requiring skilled wound care. Plus, the risk of lymphangiosarcoma, while still low, is higher in very long-standing cases.
So it sounds like the diagnosis is often made based on that thorough history and physical exam, especially if the picture is classic. But sometimes tests are needed. What are the goals of doing additional tests?
Right. In many straightforward cases, especially moderate to severe lymphedema with a clear history, the diagnosis is clinical, but tests might be needed to definitively confirm the diagnosis if it's unclear, to assess the function of the lymphatic system, to rule out those other conditions on the differential diagnosis list, or to objectively document the severity for baseline or tracking treatment response.
Are blood tests helpful for diagnosing lymphedema itself?
Not usually for diagnosing the lymphedema directly. Standard lab tests, blood counts, kidney function, liver function, thyroid tests, maybe blood sugar, are primarily used to exclude other systemic causes of swelling, like kidney or liver failure, or to check for signs of infection if that's suspected. They might also be used to monitor the impact of lymphedema or its treatment on other health conditions.
Okay. What about imaging or tests that look specifically at the lymphatics or blood vessels?
A venous duplex ultrasound is often one of the first tests done, especially with new onset leg swelling. Not to diagnose lymphedema, but to quickly and reliably rule out a deep vein thrombosis, DVT. That's crucial because a DVT needs immediate anticoagulation treatment.
Makes sense. Rule out the clot first. What about imaging the lymphatics themselves?
The most commonly used test today to directly assess lymphatic function is lymphoscintigraphy.
Lymphoscintigraphy, how does that work?
It involves injecting a very small amount of a radioactive tracer, usually into the web spaces between the toes or fingers. It stings a little bit. Then the patient might exercise the limb slightly to encourage uptake. A special gamma camera takes images over time, maybe at 30 minutes, 1 hour, 3 hours, sometimes even 6 hours later.
And what does it show?
It allows the clinician to visualize the lymphatic pathways. They look at how quickly the tracer moves up the limb, whether it appears in the regional lymph nodes like the groin or armpit, and how quickly, normally within about 15-60 minutes, the pattern of the vessels. Are there normal ascending channels or are there abnormal collateral pathways or backflow into the skin? The number and appearance of the nodes, and whether the tracer eventually reaches the liver, indicating systemic circulation.
So it can show if things are blocked or slow.
Exactly. Abnormal results might include delayed or absent tracer movement, visualization of dermal backflow, meaning fluid is pooling in the skin capillaries, reduced or no uptake in the lymph nodes, or abnormal accumulation of tracer somewhere along the pathway. While it usually can't pinpoint the exact cause, like primary versus secondary, it can identify patterns suggestive of aplasia, missing vessels, hypoplasia, underdeveloped vessels, or hyperplasia, dilated vessels in primary lymphedema. It's generally considered reliable and safe.
Are CT scans or MRIs useful?
They can be, but usually for different reasons. A CT scan's main value in this context is often to exclude an obstructing mass in the pelvis or abdomen that could be causing secondary lymphedema. It might show a characteristic honeycomb pattern in the subcutaneous tissue of a lymphadematous limb due to the fluid-filled channels, but it doesn't show the lymphatic vessels themselves well.
NRI.
MRI can be particularly useful for evaluating congenital vascular malformations or soft tissue tumors. It can also help differentiate lymphedema with its typical fluid signal changes from simple edema or from lipedema, which shows excess fatty tissue. It provides excellent anatomical detail and can complement lymphocontigraphy by showing the status of lymph nodes, large lymphatic trunks, and tissue changes, especially if proximal obstruction is suspected.
The sources mentioned older, more invasive tests, too, like lymphangiography.
Yes, direct lymphangiography used to be considered the gold standard. It involves surgically isolating a tiny lymphatic vessel in the foot or hand, cannulating it, and injecting an oil-based contrast dye. Then x-rays are taken over hours, even days.
Sounds notable.
It is lengthy, uncomfortable, technically difficult, and carries risks, including allergic reactions to the dye, infection, and even potentially worsening the lymphedema due to the inflammatory reaction to the dye. It's very rarely used for routine diagnosis anymore. Its main indications now might be for preoperative planning for complex lymphatic microsurgery or for evaluating things like chylous reflux or lymphatic fistulas.
So, mostly non-invasive imaging now. What about just measuring the limb?
Objective measurements are really important for documenting severity and tracking change. Circumferential measurements taken at regular intervals, like every 4 centimeter, up both limbs allow for comparison and volume calculation. Water displacement plethysmography, measuring the volume of water displaced when the limb is submerged, is another very accurate way to measure volume, though less practical clinically. These provide objective data.
Okay, so the diagnosis is made, other causes are ruled out. Since there's no cure, what are the main goals of management? What are we trying to achieve?
The primary goals are really about improving quality of life and preventing things from getting worse. Specifically, we aim to reduce the size of the swollen limb as much as possible, maintain that reduction, preserve or improve the health and condition of the skin, maintain or improve limb function and mobility, prevent complications like infection, and crucially, educate and empower the patient for lifelong self-management.
What are the absolute core therapies, the non-surgical pillars?
The cornerstones are really limb elevation, compression therapy, meticulous skin care, and exercise, plus manual lymph drainage in many cases.
Let's break those down. Elevation.
Simple elevation, raising the affected limb above the level of the heart whenever resting, uses gravity to help fluid drain out of the limb. Using pillows, foam wedges, or slings can help. Even doing this for 20-30 minutes 2-3 times a day can be beneficial, especially in earlier stages, or to help manage fluctuations. For inpatients, strict bed rest with elevation can significantly reduce volume initially, except in very advanced fibrotic stages.
And compression therapy, that sounds key.
It is absolutely fundamental. Compression provides external pressure that counteracts fluid accumulation in the tissues, helps push existing fluid into the veins and functioning lymphatics, improves the efficiency of the muscle pump when moving, and prevents the limb from swelling up again after it's been reduced. There are different types.
Like the bandages and the garments?
Exactly. In the initial intensive phase of treatment, therapists often use multi-layer compression bandaging with short stretch bandages. These bandages don't stretch much, so when the muscles contract underneath them, they provide a firm resistance, creating high working pressure that helps pump lymph. They provide lower pressure when the limb is at rest. They're applied with a gradient, tightest at the hand or foot, and gradually decreasing up the limb. Foam padding might be used underneath to protect bony areas or help soften fibrotic tissue.
And the garments, sleeves or stockings.
Right. Elastic compression garments are typically worn during the day, after the limb size has been reduced as much as possible through bandaging, MLD, or other means. Their job is to maintain that reduced size and prevent reaccumulation of fluid. They provide a consistent resting pressure. They come in different compression classes or strengths, prescribed based on the severity and location of the lymphedema. For example, a higher compression class might be needed for leg lymphedema compared to arm lymphedema, or for stage 2 versus stage 1.
Are there other compression options?
Yes, there are some non-elastic devices that use Velcro straps or adjustable bands, which can be easier for some patients to put on and take off themselves compared to multi-layer bandages. There are also pneumatic compression pumps.
The pumps that inflate.
Yeah, these are sleeves or boots with multiple air chambers that inflate sequentially, starting at the hand foot and moving up the limb to milk the fluid proximally. They can be a useful adjunct, especially for home management if applying bandages is difficult. However, it's important they're used correctly with appropriate pressure settings, and they primarily move fluid within the limb. If there's a blockage at the root of the limb, like the groin or armpit, the pump can sometimes cause fluid to accumulate there. So careful monitoring is needed. They also have specific contraindications like active infection, blood clots, or uncompensated heart failure.
Skincare sounds like it needs constant attention.
It's non-negotiable. Meticulous skincare is one of the most critical aspects of preventing complications, especially infection. This means daily cleansing with a mild pH-balanced soap, drying thoroughly but gently, patting, not rubbing, especially between fingers and toes and in skin folds. Applying a good quality non-irritating moisturizer, like lanolin-based, avoiding perfumes or alcohol, is essential to keep the skin supple and prevent cracking. Daily inspection of the entire limb for any signs of redness, scratches, cuts, blisters, or infection is vital.
And treating any problems immediately.
Immediately. Any break in the skin, no matter how small, needs to be cleaned thoroughly with soap and water or antiseptic, have an antibiotic ointment applied, and be covered with a clean dressing, and monitored closely. Preventing and treating fungal infections, like athlete's foot, is also key, often requiring antifungal powders or creams because those fungal infections create breaks in the skin where bacteria can enter. Good nail care is important too, avoiding cutting cuticles, trimming nails straight across.
You mentioned manual lymph drainage, MLD. Tell us more about that.
MLD is a very specific, gentle manual technique, usually performed by a certified lymphedema therapist. It was pioneered by Emil Vater back in the 1930s. It involves light, rhythmic, circular, or pumping hand movements applied to the skin. The goal is not deep massage, but rather to stimulate the superficial lymphatic capillaries and collectors, encourage fluid uptake, and gently direct the lymph flow around areas of blockage towards adjacent healthy lymphatic territories that can handle the fluid load.
So it's rerouting the fluid.
In a way, yes. Therapists often work on the trunk and the areas proximal to the swelling first, sort of clearing the pathways before moving fluid out of the affected limb itself. It can help soften fibrotic tissue as well. It's typically done as part of a course of treatment, often daily initially for maybe an hour or so, followed by compression bandaging. Patients are usually taught a simplified self-MLD sequence to continue at home. Like pumps, MLD also has certain contraindications like active infection, recent blood clots, or certain heart conditions.
And these therapies are often used together, right, in CDT?
Exactly. The gold standard comprehensive approach is often referred to as complex decongestive therapy, or CDT, sometimes called complete decongestive therapy. It integrates all these components. There's usually an intensive phase 1, which involves daily sessions with a therapist, including MLD, meticulous skincare, multi-layer compression bandaging, often worn 24 hours a day except for bathing, and specific remedial exercises performed while wearing the bandages. This phase continues until the limb volume reduction plateaus, maybe for 2-4 weeks or longer. Then comes phase 2, the maintenance phase. This is lifelong self-management by the patient. It involves diligent continuation of skincare, wearing compression garments during the day, often applying bandages or alternative compression wraps at night, performing their self-MLD routine, and continuing with regular exercise. The goal is to maintain the gains made in phase 1 and prevent recurrence of swelling or complications.
You mentioned exercise in the bandages during phase 1.
Yes, that's a key part. The bandages provide that firm resistance, so when the patient performs specific exercises, the muscle contractions push against the bandages, creating a very effective pumping action on the lymphatics. Even just simple movements like flexing and extending the ankle or wrist, or making a fist done repeatedly while bandaged, can significantly enhance lymph flow. Swimming and water-based exercises are also often recommended because the water itself provides gentle, graded compression.
Does CDT work well? What kind of results do people see?
Response varies, but the goals are typically to achieve a significant reduction in limb volume, maybe 40–70% reduction from the initial swollen state. Studies cited in the sources show variable results, sometimes averaging around 33–68% reduction. It requires a very high level of patient motivation, commitment, and adherence, as it's a demanding regimen, especially initially. Regular follow-up with the therapist is usually needed to adjust the plan and ensure things are on track.
What about diet? Does that play a significant role?
Diet is important, primarily in the context of weight management. Maintaining a healthy body weight, ideally a BMI in the normal range, around 19–24, makes lymphedema significantly easier to manage. Excess body fat increases the fluid load, can physically impede lymphatic and venous return, puts strain on joints, limits mobility for exercise, and increases the risk of skin infections and folds. So, achieving and maintaining a healthy weight is strongly encouraged.
Any specific diet recommendations?
Generally, a balanced, healthy diet, low in saturated fats and sodium, rich in fruits, vegetables, and fiber is advised. Adequate hydration is important. One key point the sources make is that patients should not unnecessarily restrict protein intake. Adequate protein is essential for tissue repair and overall health. There's no evidence that specific lymphedema diets or supplements like grapeseed extract or bioflavonoids, which are sometimes marketed, provide significant benefit.
And medications? Are there pills to reduce the swelling?
Unfortunately, no. There are currently no medications specifically approved or proven to effectively reduce lymphedema fluid by targeting the lymphatic system itself. Diuretics, or water pills, which are used for other types of edema like heart failure, are generally not recommended for long-term management of lymphedema. They primarily remove water from the body, but they don't remove the excess protein trapped in the tissues. This can potentially lead to a higher concentration of protein remaining, which might worsen fibrosis over time, and can also cause dehydration or electrolyte imbalances. They might have a limited role in very early, purely pitting edema, or perhaps short-term for managing cyclical swelling related to menstrual cycles, or in palliative care for terminal malignancy, but not as a primary treatment.
What about other types of medications mentioned? Benzopyrones?
Yeah, benzopyrones like flavonoids or coumarin have been used in some countries, particularly Europe and Australia. The theory was they might help break down the excess protein in the tissues, but they require very long-term use, like 6 months or more, to see any effect. And importantly, U.S. trials generally failed to show significant benefit, and concerns about potential liver toxicity led to them being withdrawn or not approved by the FDA for this use. Research continues on newer agents, but nothing is standard practice yet.
But antibiotics are crucial.
Absolutely crucial, but only for treating or preventing infections. They don't treat the lymphedema swelling itself. If a person develops cellulitis or lymphangitis, prompt treatment with appropriate antibiotics, covering common skin bacteria like strep and staph, is essential, usually for at least 10 days. For patients who suffer from frequent recurrent infections, say more than 4 to 6 episodes a year, doctors might prescribe prophylactic antibiotics either taken for a week each month or a low dose taken daily to try and prevent these flares. And it's always vital to look for and treat the source of infection entry, like fungal infections or skin cracks.
And for filariasis?
For filariasis-induced lymphedema, specific antiparasitic medications like DEC or ivermectin are used to kill the worms, often as part of large-scale public health programs. Mosquito control and personal protective measures are also key in endemic areas.
It really sounds like living with lymphedema impacts almost every aspect of life. The sources really stress the psychological impact.
They did, and rightly so. It can be profound. Imagine dealing with a chronic condition that often causes visible disfigurement, requires constant daily management, limits activities, and carries a risk of painful complications like infection. For people with primary lymphedema, especially if it starts young, dealing with body image issues, feeling different, potential isolation can be very difficult. For those with secondary lymphedema, often after cancer treatment,
A constant reminder.
exactly. It can be a constant, unwelcome reminder of their cancer experience and feel like an overwhelming burden after already going through so much. There can be a real sense of loss of normalcy, loss of ability to wear certain clothes, participate in certain activities, sometimes loss of job or financial strain, impacts on relationships and intimacy. Anxiety about infection, about the condition worsening is very common. Assessing for and addressing depression and anxiety is a vital part of care. Support groups can be incredibly helpful.
And the functional impact on just moving and doing things.
It can be significant. The sheer weight and bulk of a swollen limb can cause heaviness, aching, fatigue, and stiffness, making movement difficult. This can limit participation in sports, hobbies, and even basic daily tasks. Job modifications might be necessary, especially if the job involves prolonged standing or sitting, heavy lifting, or exposure to heat, all things that can exacerbate lymphedema. Lost work days due to infections or flare-ups are also common. Physical and occupational therapists are key members of the team, helping with strategies to maintain function, adapt activities, and manage limitations.
So this brings us to the real practical takeaways. For anyone listening who is living with lymphedema, or perhaps at risk, or supporting someone who is, what are the most crucial "what can you do" points from these sources for daily life and preventing problems?
Prevention is really the name of the game, preventing the edema from worsening and preventing infection. For managing the swelling itself, the absolute key is consistent and correct use of compression. That means wearing the prescribed garments during waking hours and often using short stretch bandages or specialized nighttime garments when sleeping.
Right, consistency.
Regular elevation of the limb whenever resting is also important. Avoiding heat is a big one. Limit exposure to hot sun. Avoid hot baths, showers, saunas, hot tubs. Use caution with cooking or activities involving heat near the affected limb. Try to avoid overuse or strain of the limb-based activities. Avoid heavy lifting or repetitive motions if they are known to increase swelling. Listen to your body.
What about clothing and procedures?
Avoid tight clothing or jewelry on the affected limb. Crucially, never allow blood pressure measurements, injections, IV lines, or blood draws on the affected or at-risk limb if at all possible. Wear a lymphedema alert medical bracelet to inform healthcare providers. If you have an injury like a sprain, manage it promptly with RICE, rest, ice, compression, elevation, and notify your provider. If you travel, especially by air.
Yeah, the pressure changes.
Right. Plan ahead. Wear your compression garment during the flight. Get up and move around frequently. Do ankle pumps or hand clenches. Stay well hydrated with water, not caffeine or alcohol. And consider discussing antibiotic prophylaxis with your doctor if you're prone to infections. And always report any new or worsening swelling to your healthcare team promptly.
And preventing infection, that sounded paramount.
Absolutely paramount.
Yeah.
This requires meticulous daily skincare. Keep the limb clean and dry, especially in skin folds and between digits. Moisturize daily to prevent dryness and cracking. Inspect the skin every single day for any signs of redness, warmth, cuts, scratches, insect bites, blisters.
And treat any break.
Treat any break in the skin immediately and seriously, no matter how small. Wash thoroughly. Apply antiseptic or antibiotic ointment. Cover with a clean dressing. And monitor closely for signs of infection. Be proactive about preventing injuries. Wear gloves for gardening or washing dishes. Use insect repellent. Use an electric razor instead of a blade for shaving. Get prompt treatment for any fungal infections like athlete's foot or nail fungus. See a podiatrist for foot care if needed, especially if you have diabetes.
What about general health promotion?
Maintaining that healthy weight is key. A balanced diet, adequate hydration, 2-3 quarts of water daily unless advised otherwise. Regular appropriate exercise is strongly encouraged. Things like walking, swimming, cycling, water aerobics are often ideal. Gentle stretching and deep breathing exercises can also help lymphatic flow. Avoid smoking as it impairs circulation and healing. Get adequate rest and try to avoid prolonged pressure on the affected limb during sleep. And maintain regular follow-up with your doctor and lymphedema therapist.
And if someone does suspect an infection starting at home, what should they do?
First step is to contact their healthcare provider or seek emergency care immediately. Don't wait. If they have been prescribed antibiotics to keep on hand for such situations, they should start taking them as directed. Crucially, while an infection is active, they should remove all compression garments or bandages. Do not use a compression pump or perform MLD on an actively infected limb. Keep the limb elevated, monitor temperature, drink plenty of fluids, and follow up with the provider if things aren't improving within a couple of days. The limb will likely swell more after the infection resolves and may require extra therapy sessions to get it back down before resuming regular garment use.
Okay, let's bring it back to SR, the 54-year-old butcher we met at the start, with the new left leg swelling after his prostate cancer treatment. Based on everything we've discussed from the sources, what's likely going on with him?
Well, given his clear history, prostate cancer surgery and radiation 2 years prior, followed by the gradual onset of painless, non-pitting swelling in that same leg, this is almost certainly secondary lymphedema. It fits the classic picture of lymphedema developing as a delayed consequence of cancer therapy involving the pelvic lymph nodes, which is, as we said, the most common cause in developed countries.
And based on his exam findings, the non-pitting edema that doesn't get better with elevation, the taut skin, the squared toes, what stage would you say he's likely in?
That description strongly points to stage 2 lymphedema. The fact that it's non-pitting and doesn't resolve with elevation tells us that significant fibrosis has already started to develop in the subcutaneous tissues, even if his skin hasn't yet reached those extreme stage 3 changes like thickening and hardening.
So for SR in stage 2, what kind of management approach would the sources typically recommend?
For established stage 2 lymphedema, the standard of care is comprehensive management, ideally CDT. That would involve an initial intensive phase of MLD, multi-layer short-stretch bandaging to reduce the volume, skin care, and exercise. This would then transition to the lifelong maintenance phase.
Right.
Using a high-quality, properly fitted daytime compression garment, likely class 2 or 3 for the leg, Possibly nighttime compression, continued skincare, self-MLD, and regular exercise. Pneumatic compression pumps could be considered as an adjunct for home use. Elevation is still helpful when resting. Diuretics would generally not be indicated unless he had another condition like heart failure, which wasn't mentioned. Exercise like walking is encouraged, but he might need guidance on managing his standing job or avoiding excessive strain on the leg. A low-salt diet would also be advised.
And what other aspects of SR's overall health and situation are important to address based on the sources?
Definitely his smoking history. That's a major cardiovascular risk factor and needs addressing. The family history of AAA warrants screening. His job as a butcher with prolonged standing is clearly an aggravating factor, so counseling about work modifications, frequent position changes, or even exploring alternative employment might be necessary. But encouraging safe recreation, like his golf, while monitoring the limbs response is important for quality of life.
And finally, thinking about patient education for SR, what are those absolute must-know critical takeaways for him?
He absolutely needs to understand the critical importance of daily skin inspection and meticulous skincare to prevent infection. He needs to know to elevate the leg whenever possible when not standing or walking. He should understand not to restrict fluids or protein in his diet unless advised for other medical reasons. And he needs clear, practical instruction on how and when to use his compression garments during the day to maintain the reduction achieved, not usually 24/7 unless it's specific bandaging during an intensive phase. And crucially, know the signs of infection and seek help immediately if they occur.
Wow. We have certainly covered a huge amount of ground today, digging into these sources, from the tiniest lymphatic capillaries right up to the day-to-day realities of living with this condition.
We really have. We've unpacked what lymphedema is, explored the fascinating lymphatic system it affects, looked at why it happens, how it's diagnosed, and the comprehensive strategies needed to manage it. It's complex, no doubt.
I think the key takeaways for me are really clear. It's chronic, there's no easy fix right now, but effective management is possible. Early detection, consistent self-care, especially that skincare and compression, seem absolutely vital to slow things down and prevent complications. And it's just so much more than swelling. It really impacts every part of a person's life.
It truly does, and it makes you stop and think, doesn't it? How a disruption in this hidden highway, the seemingly background system for fluid transport, can lead to such a complex, progressive, and challenging condition. A condition that demands lifelong vigilance and profoundly affects not just the body, but work, social interactions, emotional well-being. It really underscores the intricate balance within